Welcome to the second presentation on GMDC preparation. This is surgery, GMDC preparation. Let's begin right away. If you're new here, you might want to subscribe for more. So a 50-year-old man was involved in a road traffic accident and sustained a closed fracture of his left tibia and fibula. Closed fracture. So as a physician, you must know the difference between a closed fracture and an open fracture. So what then is a closed fracture? So in a closed fracture, the skin that is surrounding the fracture is intact. That means there's no broken skin. So that means in an open skin or in a compound fracture, the broken end of the tibia punches through the skin, or there is a wound that shows the bone. So that's the difference between a closed fracture and an open fracture. So basically this is what we mean. So over here you can see a broken skin. So that means this is an open fracture, an opened fracture. But over here we're talking about what? A closed fracture. A closed fracture. Alright, so let's look at the possible questions they might be asking us on this one. So indicate 3 ways in which you can stabilize the fracture. So a bone is broken. How will you stabilize this patient? What way? So 1, you can talk about the reduction by a closed manipulation and limb immobilization. Reduction by closed manipulation and limb immobilization. In other words, full length plaster cast. Full length plaster cast. So basically this deals with what we call the POP, if you might have heard it before. POP, so full length plaster cast. That's one way in which you can stabilize the fracture. Another way is what we call the patella bearing plaster. Patella bearing plaster, where you immobilize the fracture of the tibia shaft and at the same time you allow the knee to bend. That is called the patella bearing plaster. Then we have the external fixation. Then you can talk about the functional bracing. Then we have operatively, you can talk about what we call the ORIF. That is open reduction and internal fixation. Open reduction and internal fixation. So these are some of the ways in which you can stabilize this fracture. So again, reduction by close manipulation and limb immobilization, that's to say a full length plaster cast or a POP. Secondly, you can do a patella bearing plaster. It's also a form of POP. Then you do the external fixation, functional bracing, and ORIF, open reduction and internal fixation. So these are the possible ways in which you can stabilize the fracture. List 2 early complications of this fracture. So basically, when there is a fracture, one of the things that you can see or you're likely to see is what there can be a skin damage. So skin damage is very common. It's one of the complications of a fracture. Then arterial damage. So these are the 2 early complications you might be thinking about for this fracture. For late complications. So in late complications, you are talking about what? A delayed union, non-union, malunion, and joint stiffness. Again, delayed union, non-union, malunion, and joint stiffness. So these are the possible late complications for this fracture. Normally, most of the fractures, these are the possible late complications that you can find. Any fracture. I mean, most of the fractures. Let me put it that way. Most of the fractures. So put all of these things at the back of your head because you can always apply it in your exams. All right. Good. So this is just a diagram to show you what we talked about in the stabilization of a fracture. So this is the patella bearing plaster, the patella bearing. So if you can see over here, we have applied the POP above and below the knee, above and below the knee. So that means it helps to stabilize this area. It can stabilize this area, that's the thigh, and can stabilize the leg, but leaving the knee so that you can bend it. You can bend it. All right. Then also have this, the external fixation. The external fixation. So you can see there's a fracture in there. The shaft of the tibia is there, is broken, and they've plastered it, or they've screwed it. Let me put it that way. They've screwed it, and they've brought it what outside. So that's called the external fixation. This is called the external fixation. So in case you have not seen it before, and this is what internal. So yes, this is the ORIF, the internal fixation, the ORIF. All right. So it's done inside, and this is the most common, the POPs. So we have short leg cast, leg cylinder cast, and then long leg cast. So all of these are all this. You can read more about these things in BAHA. You can read more about them. All right. Yeah. So we have a 70-year-old woman who stumbled. 70-year-old woman. So the age is very important. Who stumbled and fell, and she was unable to get up. Her right lower limb was found to be shorter and laterally rotated. 70-year-old woman fell, cannot get up, then the limbs are not equal. The limbs are not equal, or the limb is not equal. So what comes to your mind? What comes to your mind? This is very, very common in our settings. A lot of old age people, they fall, and then funny enough, they cannot do anything again. So you should always be on the high suspicion when somebody falls like that. So what should you be thinking about? So this brings us to our question: what is your clinical diagnosis? And over here, you are thinking of what? A displaced right femoral neck fracture. A displaced right femoral neck fracture. So normally, the femoral neck connects the femoral shaft with the femoral head. Now the hip joint is the articulation of the femoral head with the acetabulum. The junctional location makes the femoral neck prone to fracture. So anytime there is fall, now basically the reason why it is also very prone is also because of the old age. Because you can, of course, young guys can fall and there's nothing, but at old age, easily when you fall, you can develop what? A fracture. And also that's also because of what? Osteoporosis in the elderly. So that means diseases of the bone makes the bone very weak for it to be easily what? Fractured or broken. Alright, so over here, you are thinking of what? A right femoral neck fracture. Again, old age, history of a fall, and cannot get up. Very, very diagnostic for a femoral neck fracture. All right. How will you classify this type of injury? So we have some classification that you must know from BAHA. You should know all of these things. You should know them. So for the classification, you can classify into two major categories. We have what we call intracapsular. Intracapsular. So if you have intracapsule, that means capsule, inside the capsule. That means we can also have what we call the extracapsular. So we have intracapsular and then extracapsular. So what is found in the intracapsular? You are thinking of subcapital, and then transcervical fractures. So subcapital neck fracture, transcervical neck fracture. Don't worry, I will show you a diagram later on for you to look at the basic, what I mean by all these fractures. Then for the extracapsular, you are thinking of what? The basal neck fracture Petrochanteric fracture, and then subtrochanteric fracture. I repeat, basal fracture, petrochanteric, and then subtrochanteric. I'll show you a diagram, so don't worry. All right, so these are the ways you can describe or you can classify this type of what? Fracture or injury. What are the two complications of this injury? Again, this is a bone, isn't it? So you can talk about what we spoke about in the previous one, like the delayed union, non-union, malunion, and then joint with stiffness. But most importantly, over here, you can think of the avascular necrosis as well. Avascular necrosis. That means the vessels are not getting what? Blood supply. So avascular necrosis. Avascular necrosis. Then you can add the rest to it. So this is very, very specific for the femoral neck fracture. So please take note of that. All right. So like I said, I will show you some diagrams. I'll show you a diagram over here for you to look at the different types of neck fracture. We classify them into what? Intra and then extra. So over here, so this is what we can start from here. The subcapital neck fracture. So you see, this is the head of the femoral bone. Let me put it that way. This is the head of it. So just underneath it, that's what subcapital means. Under the head, subcapital neck. So this whole thing is a neck. From here to here is all part of the neck. It's all part of the neck. Alright, so we have the subcapital neck fracture. So over here, just under it, there's a fracture over there. That classifies it as what? Intracapsular. Then we have the transcervical neck fracture. As you can see, it is in the middle of the neck. So transcervical neck fracture. Then we have the, actually this is supposed to be the perhaps the basal, isn't it? The basal, but we call it what? Intratrochanteric fracture. All right, good. Intratrochanteric fracture. Then we can talk about the subtrochanteric fracture. The subtrochanteric fracture. They are all there. They are all here. Then we have the greater trochanter fracture is here, and even the lesser trochanter. That is what? Also there. So all of these can be described as what? As extracapsular. Extracapsular. That means outside the capsules. Outside the capsules. So that what means is that over here they are covered by what? A capsule, but the rest are not covered by a capsule. All right. So that is just by the way. So we have a 60-year-old man who was brought to the emergency room complaining of severe total hematuria. Severe total hematuria. He is pale, blood pressure, the BP is what? 90/60, and the pulse is 120 beats per minute. 120 beats per minute. So we see this a lot in the surgical department. We see it a lot. People will come, they are bleeding seriously. So what comes to your mind? You need to have a high index of what? Suspicion. So you have to have what? A lot of differentials in your head. So list 3 possible causes of his hematuria. 3 possible what? Causes. So we can have 1, urologic trauma. That means trauma to the renal or to the kidney, trauma to the urethra, trauma to the ureters, and even trauma to the bladder. So the urinary system, every single part of it can have trauma, or there can be trauma over there. So you need to rule them out or rule them in. So renal trauma, urethral trauma, ureter trauma, or trauma of the ureters, and then trauma of the what? Of the bladder. That's a possible what? Cause. Another thing is when there is a cancer in the bladder. So bladder cancer. But normally in bladder cancer, what I know is that it comes with it's a sort of painless. But of course a differential. It's a differential because you always include it. So bladder CA. Then we have carcinoma of the kidney. carcinoma of the ureter. We have prostate cancer. We have BPH, benign prostatic hyperplasia. We have vesical schistosomiasis. So all these infections, schistosomiasis, can also lead to what? To hematuria. So list any three of them. So again, we have urologic trauma, that is renal, urethra, ureters, bladder. So trauma in all these areas. Secondly, cancers in all these areas, like the bladder, cancer of the kidney, cancer of the ureter. You can talk about cancer of the prostate, and then benign prostatic hyperplasia or BPH, then schistosomiasis or vesical schistosomiasis. All of these are possible causes of hematuria. So you can mention them. All right. So indicate 3 diagnostic investigations that you would carry out. 3 diagnostic investigation. So you want to know why. Why is this person, or how can you make a diagnosis out of this? So basically, you do your what? You can do your plain abdominal X-ray. If you are suspecting what? A calculi. Plain abdominal X-ray if you are suspecting a calculi. They can do intravenous urogram. You can also do cystoscopy. You can do urine for culture and sensitivity. You can do urine for cytology. You can do your urine analysis. That's the routine urine examination. You can do your BUE creatinine, blood urea creatinine and electrolyte. BUE and creatinine. You can do your grouping and cross matching, because this person is definitely might need blood. If you check the HbN is low, so you should do your grouping and cross matching. They can also do a CT scan to be ordered by a senior person. CT scan. So again, what are the possible? And again, I forgot to add, you can also do your full blood count, sickling and clotting screen. So these are the major diagnostic investigations that you can carry out. So again, full blood count, sickling, clotting screen, grouping and cross matching, urea creatinine and electrolyte, urine analysis, urine for culture and sensitivity, urine for cytology, plain abdominal X-ray if calculi is suspected, intravenous urogram, cystoscopy, and a CT scan. So these are the possible investigations you can carry out. So just 3 of them and you are good to go. Indicate briefly your initial treatment of this patient. So somebody is bleeding, okay, or there's hematuria, very severe one. So it's an emergency case, isn't it? So you always have to do your emergency assessment, or how to assess emergency cases. So first of all, you have to do your protocol. That's your ABC. Make sure that the person is stable. Airway, breathing, circulation, everything is intact. Okay. So basically do your resuscitation measurement. Then you relieve the pain by giving any analgesic. So you can give petadine or even morphine if it is very severe. Okay. Then of course you can pass your catheter. However, if the person is having a trauma, or if you're suspecting a trauma, please, catheterization is contraindicated. It is contraindicated. But if the person, maybe you're thinking of a bladder problem or prostate problem and things like that, you can pass a urethral catheter to help or to facilitate the washing out of the clot. My boss will let us do what we call a 3-way catheterization for us to flush the bladder, if I should put it that way. Okay. So you do that continuously, you realize that patient will be fine. Or the clotting will perhaps improve. All right. Then you have to give your antibiotics. So IV antibiotics. You should give them IV antibiotics. So you can give your Cipro, your Metro. Okay, Cipro, Metro, or even Cefuroxime. So you can give all of these things. So normally I tell people that if you're writing exams and you're not sure of the drugs, don't mention them. Just write antibiotics. At this level, if you write antibiotics, you are good to go. No need to worry yourself with that, unless things that they want you to really tell them. Then for that, you must know how to give the exact dose. Example, malaria question. You should be able to know how to tackle it. Okay. Then, what will you do? You continue further in what? Investigations. You do bed rest. Do bed rest until the urine what? Clears anything. So make sure that bed rest is ensured until the urine is what? Is cleared. The urine is cleared. Then you must also what? Observe. So observing, you should do your what? Your basic protocols in terms of vitals checking. The pulse, the blood pressure, whatever. Check them out. All right. Then you might want to also monitor the inputs and outputs. Urine input and urine what? Output. You might want to what? Check it. So fluid intakes, very what? Important. Fluid intakes is very what? Important. So your fluid management, monitoring the input and output, ensuring bed rest, doing further investigations, giving your antibiotics, passing a catheter, relieving the pain, and resuscitation. And of course, you can't do all of these things without what? Admitting the patient. So you must first what? Admit and then do all these things. All right. So these are your initial treatments for this patient. What is the most likely diagnosis? So the most likely diagnosis could be a malignancy of the bladder, the ureter, or the renal system. Talk about malignancy. So please take note of that. And usually, like I said, so since they're saying that severe total hematuria, it doesn't necessarily mean that it is painful. No. What I mean is that the hematuria is gross. So you can literally see blood or blood clots. You can literally see it. So it's very severe. So they can be what? A malignancy. So please take note of that. All right. So list 6 complications associated with malignancy of either the bladder, the ureter, or the renal. So renal carcinoma or bladder carcinoma or uteric carcinoma. Let's mention 6 complications. So they include 1, hemorrhage and anemia. Then we can have what? Cystitis. We can have progressive hydronephrosis, and even hydroureter. So hydronephrosis, that means water accumulation inside the kidney. We can have hydroureter, accumulation of fluid inside the ureters from a possible what? Obstruction, which may lead to what? Renal failure. So hemorrhage, anemia, cystitis, progressive hydronephrosis, and hydroureter, which eventually can lead to what? Renal failure. They can talk about retention of urine, also from possible what? Obstruction of the bladder or the clot. So retention of urine. You can talk about fistulas, retrovesical, fistula, constipation, diarrhea, and acute intestinal obstruction. These are all possible what complications. You can think about priapism. Yes, priapism, priapism, priapism. You can think of a unilateral or a bilateral lower limb edema from a possible lymphatic or venous block. So unilateral or bilateral lower limb edema from a lymphatic or a venous block. All of these are all very, very important. There can also be infiltration of the pelvic nerve plexus with resulting severe intractable pain. Very important. Very important. So again, hemorrhage and anemia, cystitis, hydronephrosis, hydroureter, retention of urine, fistula, constipation, diarrhea, acute intestinal obstruction, unilateral or bilateral lower limb edema, priapism. All of these are possible complications of urologic malignancy. Urologic malignancy. So please take note of that. All right. So we have a 40-year-old alcoholic and a tobacco user present with a 6-hour history of a severe abdominal pain and retching. All right. The pain radiates around the trunk to his back. He admits to alcohol ingestion the previous night. Okay. He is moderately dehydrated and there is tenderness in the upper abdomen. Tenderness in the upper abdomen. So this is something we see it all the time in our settings. People who drink at the same time smoke, okay, they can come with severe abdominal pains, upper abdominal pains. So you have to start thinking, people who like drinking a lot, what are some of the possible things you are likely to see or they are likely to experience? Very, very, very important. Now, localization of pain is important in helping you to make a proper diagnosis. Okay. Now, if they tell you pain is at the right upper part or right hypochondria, you know what to think about. The upper part of the abdomen, you should know what to think about. So this is not really on the right side, but mainly on the middle side. So you ask yourself, which organ can be found in the middle that in a way has connection with alcoholism? Yes, with alcoholism. So what comes to your mind is what? The pancreas. The pancreas. The pancreas. That comes to your mind. The pancreas. Very, very important. The pancreas. All right. So what is your diagnosis? Of course, we're talking about acute pancreatitis. Acute pancreatitis. Acute pancreatitis. What investigation would you do to confirm your diagnosis? So again, if you think of a pancreas, you ask yourself, what do you think about? Definitely, you want to do what? A serum amylase or lipase, because the pancreas produces these substances, right? So you want to see the level of the amylase or the lipase in serum. So serum amylase or lipase, very, very important. Do them. Then later on, you can add your ultrasound. But diagnostically, you want to do what? Serum amylase or lipase if you are thinking of what? Pancreatitis. All right. So we have a 50-year-old man who presents at the emergency room with a 1-week history of fever, pain in the right upper abdomen. Again, in contrast to the previous one, look at it. In the right upper abdomen, not just the upper abdomen, in the right upper abdomen. So you start thinking of which organs that are found over there. The organs that are found over there. So you can think of what? The liver, you can think of the gallbladder. Mainly the liver, the gallbladder should come to your mind. Now he complains of anorexia and admits to the passage of mucoid stool in recent past. He has a tinge of jaundice and a tender mass in the right upper abdomen. In the right upper abdomen. So again, so usually if questions start talking about food in terms of fat food or fried rice and things like that, then majorly what you think about is the gallbladder. Is the gallbladder. But over here, we'll be thinking more of the liver instead of the gallbladder. More of the what? Of the liver. Now, so what it means is that there's a problem with the liver, isn't it? So what problem could it be for there to have what? Fever. Fever. Okay. And now there's a passage of what? Mucous stools and things like that. Jaundice is there, and a palpable mass, tender mass. So what you are thinking about, what to call it? Amoebic liver abscess. Amoebic liver abscess. So what are your questions? What are the diagnosis? They're definitely amoebic liver abscess. Amoebic liver abscess. Very important. So indicate one investigation you will do. One, of course, ultrasound. Abdominal ultrasound scan. Abdominal ultrasound. Abdominal ultrasound. All right. Then indicate the most effective drug. So if you're thinking of amoeba, then you're thinking of what? Of course, metronidazole. 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 Very important. Give one complication that may occur in this disease. One complication. One complication. So over here, you can think of what to call a secondary bacterial infection. Secondary bacterial infection. It is one of the most frequently encountered complications. So please note it down. In terms of amoebic abscess, amoebic liver abscess, one of the major complications is a secondary bacterial infection. Then you can talk about, secondly, you can talk about what? Rupture into adjacent structures such as the pleural, the pericardial, and the peritoneal spaces. So this is what? The second commonest complication. So rupture of what? Organs or structures like the pleural, the pericardial, and the peritoneal spaces. So all of these things can rupture. They can all rupture. So these are your possible what? Complications. So just mention just one. So secondary bacterial infection or rupture of adjacent, or rupture into adjacent structures. Rupture into adjacent structures. All right. So lovely people, this brings us to the end of this presentation. And if you love it, do well to subscribe and share. Let us know what you think about it in the comment section. If you have any question, please feel free to let us know in the comment section, and we'll be more than ready to tackle them with you. So until then, see you in my next video.